Okay, so good afternoon, everyone. Happy Friday. I hope everyone's doing well today. Thank you so much for taking time out to join our echo session today. Before we get started, can I please have everyone set their Zoom name as their first and last name, as this helps me with identifying who is on. Thank you. So if this is not your first echo session with us, then this will look familiar. This will be the structure of our echo sessions, starting with announcements and introductions, which will be followed by a didactic session in which today's topic will be focusing on cognitive assessment, risk factors for cognitive impairment, and how to modify them. And then moving on into our collaborative case discussion, followed by closing and reminders. So to make sure the sessions run smoothly, please remember to mute yourself when you're not speaking to prevent background noise. Always introduce yourself with your name and location prior to speaking. Please maintain confidentiality when speaking about your clients by refraining from including any identifying information. And please respect others and their opinions. We are CME accredited. Our main objective is to empower providers to feel capable and comfortable with the assessment and care planning for dementia and to expand access to geriatric specialty care throughout California and beyond. So today's session is accredited for 1 CME credit, and certificates will be sent out by our CME office at the end of each month and will outline the total number of hours you attended. And many other licensing boards like the California Board of Nursing also recognizes CME for reciprocity. So our series is a part of HCBS Dementia Care Aware Award, which is supported by the California Department of Healthcare Services. One of the main goals for our grant is to create a dementia-friendly California for the population in need of equitable and excellent care. And it's also to train geriatric specialists, primary care providers, and health profession trainees and help expand our geriatrics workforce. So we would like to have everyone take the time to quickly introduce themselves on video, but since we do have quite a few individuals on the line, which is great, we'll go ahead and have everyone introduce themselves via the chat function if you can. When doing so, please list your name, role, site, and location. So in the meantime, we'll go ahead and have our hub team introduce themselves on video so you can get to know all of us. And I'll get us started. My name is Nal Khan, and I'm the project manager for our dementia care project at UC Irvine Health, and we are located in Orange County, California. So Dr. Gibbs.
This is para los ojos.
Hi, Lisa Gibbs. I'm Chief of Geriatrics, the lead for Dementia Care Aware here at UC Irvine. And I will move on to Dr. Segal.
Thank you, Dr. Gibbs. I'm Sonia Segal. I am a geriatrician here at UC Irvine, and I direct our fellowship program in geriatric medicine, and I practice at the Senior Health Center and in Laguna Hills at our UCI locations. It's my pleasure to be here today.
Thank you, Dr. Segal and Dr. Gibbs. And Dr. Lee.
Hello, everyone. My name is Jung-Ah Lee, Associate Professor in Scrub Nursing and also working with UCI Health Geriatric Medicine. And then currently we are kind of conducting the caregiver support study funded by the NIH. Nice to meet you.
Thank you, Dr. Lee. So before we get started, we will be introducing our speaker today, which is Dr. Deazambuja. So Dr. Gibbs, if you'd like to introduce her.
Yes, we're very excited to have Dr. Deazambuja speaking today to everyone. She is one of our key board certified geriatricians here at UC Irvine, trained in family medicine and then geriatrics. She practices at our Senior Health Center, which focuses on the care of senior patients, as well as our FQHC site, which focuses on seniors in underserved communities. So without further ado, I'm excited to present Dr. Deazambuja. Thank you.
Thank you, Dr. Gibbs. Hello, everyone. Good morning. I'm very excited to present on this topic, which is the cognitive assessment, risk factors for cognitive impairment, and how to modify them. Next slide, please. So the objectives for today's topic or lecture will be to identify modifiable and non-modifiable risk factors, discuss modifiable risk factors and interventions to help address these risk factors, and we'll go over a case presentation. Next slide. So this illustration here kind of goes over the more common etiologies of dementia, kind of thinking of dementia as an umbrella term for multiple different etiologies. Again, Alzheimer's dementia is the most common one. It accounts for anywhere between 60 to 80% of dementia. Second most common is vascular dementia. Lewy body is third most common. Some literature shows that Lewy body might be second most common, but I think most literature says that vascular dementia is still second most common. Then the less common forms would be frontotemporal. Other more rare forms of dementia include Huntington's dementia, HIV-related dementia, and then there's also mixed dementia, which means that there's a mixed etiology, most commonly referring to Alzheimer's dementia with vascular dementia. Next slide, please. So this slide here shows the pathophysiology of Alzheimer's dementia. Just to review that with Alzheimer's dementia, there's an accumulation of the beta amyloid plaques and the neurofibrillary tangle, the tau neurofibrillary tangles, resulting in neuronal injury. So the tau neurofibrillary tangles, essentially they are intracellular accumulation of hyperphosphorylated tau protein. And the amyloid plaques are more extracellular. So these two accumulations of these abnormal structures cause neuronal injury and death to the brain cells or the neurons. And because of that, there's a lot of brain volume loss. So on the diagram on the right, it shows a comparison between the brain of someone with Alzheimer's disease versus someone who has a normal brain. And you see a significant amount of brain volume loss, in particular in the areas of the hippocampus, and you can see the ventricles become enlarged because of the brain volume loss. Next slide. Next slide, please. This diagram shows the pathophysiology of vascular dementia versus Alzheimer's dementia. In vascular dementia, there's a more involvement of the blood flow to the brain. So the way someone would present with vascular dementia, it all depends on what vessels are affected and what part of the brain is being compromised in terms of blood flow. So if someone has less blood flow, say to the frontal regions of the brain versus someone in the parietal regions, they'll present a little bit differently, not only cognitively, but also with motor symptoms. So this is just a comparison of vascular dementia and Alzheimer's dementia. And a lot of times people have kind of a combined mixed etiology resulting in their dementia. Next slide, please. So what is the impact of risk factors in development of dementia? About 40% of dementias worldwide are prevented or delayed if these modifiable risk factors are addressed. And it's important to consider the cumulative effect of multiple risk factors over someone's lifespan. It's also important to know that dementia has a long preclinical period, meaning that it takes a while for this pathophysiology that we discussed in the prior slides for them to start causing clinical symptoms. So it's important to address these risk factors much early on before the patient presents clinically with a cognitive impairment. Next slide, please. So these are the non-modifiable risk factors that we don't have any control of. So that include age, family history, and the ApoE or epsilon-4 allele. Age is actually the strongest risk factor for developing, and particularly Alzheimer's dementia. In terms of family history, if nearly half of people with a first-degree relative with Alzheimer's dementia, meaning a parent or a sibling, will develop Alzheimer's dementia. In terms of the ApoE or epsilon-4 allele, just as a review, there's different ApoE genes. You might have heard of the ApoE4, the ApoE2, the ApoE3. It's the ApoE4 that has been associated with increased risk of developing Alzheimer's dementia. If someone has one copy of the allele, they have an increased risk. Just to give you an idea of how prevalent this allele is, about 25% of the population carries one copy. If they carry two of these alleles, they're at even increased risk for developing dementia. About 2 to 3% of the population at large have two copies. But if someone were to have one or two copies, it's not predictive that that person will definitely develop Alzheimer's dementia. So for that reason, it's not recommended to do genotyping because again, it doesn't prognosticate that someone will develop Alzheimer's dementia. It increases the risk, but it won't determine with certitude that they will develop Alzheimer's dementia. Next slide, please. So these are the modifiable risk factors that I'll be really focusing during this lecture. About 35% of dementia cases can be attributed to a combination of 9 potential modifiable risk factors, including low education, midlife hypertension, midlife obesity, hearing loss, late life depression, diabetes, physical inactivity, smoking history, and social isolation. So we'll go over those in the next few slides. Next slide, please. So I'll start with cardiovascular health. It's important to think about the really important interconnectedness between brain health and heart health. Cardiovascular and cerebral vascular diseases play a detrimental role on the brain through mechanisms including cerebral hypoperfusion and infarcts, cardioembolization, and chronic inflammation. To start off with hypertension being one of the most common things we see in our patient population, especially in the elderly, it's the most important cardiometabolic modifiable risk factor. It's associated with 1.5-fold increase in relative risk of developing dementia. And the reason it is associated with development dementia is because it increases the risk of stroke, increases the risk of multi-infarcts, and it changes the cerebral blood flow. Interventions to really modify this risk factor is good blood pressure control, because that has been proven to prevent, delay, or slow dementia. So even patients who have been diagnosed with cognitive impairment or even into dementia, we can really slow the progression if we control their blood pressure. Diabetes is associated with 1.5 to 2-fold increase in relative risk of developing cognitive decline, including dementia. The mechanism that's been hypothesized is because of how it affects the vascular system, vascular disease. And it's also been shown that it decreases, poor diabetes control decreases brain insulin production, and that could also impair the amyloid clearance, like we had spoken about with the amyloid plaques. The intervention is recommended that we take a good control of our patients' blood sugars, but also with caution that we don't control them so strictly where they have hypoglycemic events. So both with hypertension and diabetes, we want them to be under control, but we also don't want to overtreat. So that's something to think about. And in terms of lipid disorders, the evidence is not very strong about the evidence of statins delaying or preventing dementia. I think a lot of it has to do with time to benefit, especially in an elderly population. So by the time someone is of older age, there's not much evidence showing starting someone on a statin would delay dementia or prevent it from developing by the time they reach that age. So it's not proving at this point, and they're still looking into it. Obesity in midlife has been increasing the risk of dementia later in life. But there's also, you have to be careful with someone who's losing too much weight. So if there's weight loss, that can, especially in the context of frailty, we worry about older patients with too low of a BMI because that could actually precede mild cognitive impairment or dementia. And then atrial fibrillation, a lot of times we associate that with stroke risk, but there's been evidence showing that atrial fibrillation has been associated with increased risk of dementia independent of clinical stroke. So something to think about as well. Next slide, please. So in terms of other modifiable risk factors that we can work on include physical activity, socialization, and nutrition. Starting with physical activity, it's been shown that inactivity is a risk factor for cognitive impairment. And a lot of the mechanisms that they've shown include just general poor cardiovascular health. So it's been proven that engaging in low to moderate level of physical activity is associated with a 35% reduction in relative rate of developing cognitive decline. So the interventions that we usually recommend agree with the World Health Organization's recommendations of the 150 minutes of moderate intensity exercise or 75 minutes of more vigorous activity per week. In terms of social isolation and cognitive stimulation, it's been shown that people who are more isolated or more lonely tend to increase more of that brain amyloid and the tau protein that we talked about in the earlier slides in regards to Alzheimer's dementia, and that less social contact is associated with increased risk of dementia. Social contact helps with activation and enhancement of cognitive capacity, and staying mentally active encourages blood flow to the brain and promotes new pathways and new brain connections. So the interventions that we recommend for these patients are to stay socially engaged with their loved ones, with the community, visit with friends or family, engage in new friends, build new relationships, stay involved with the community, join groups or volunteer in their local day center or church. For things that they can do more on their own to keep them cognitively stimulated, we recommend reading books, playing strategic games, learning new skills is really important as well. Doing any sort of hobbies that they can learn from and keep learning. So a lot of times we recommend our patients, especially those with kind of on the milder side of mild dementia, we recommend learning new skills like a new language or taking classes at adult education center. In terms of nutrition, the two diets that have been studied and showed to have the best benefit for cognitive, to delay cognitive impairment have been the Mediterranean diet and the DASH diet. And again, a lot of that's related to the cardiovascular system and really keeping it as healthy as we can. Studies suggest that a diet rich in vegetables, especially leafy green cruciferous vegetables like broccoli, is associated with a decreased rate of cognitive decline. So things that we can do to intervene, go over the patient's diet, see where they're having issues with maybe affording healthy meals, connecting them with Meals on Wheels, or with resources in the community that's available to them so they're able to eat healthier foods. Next slide, please. So of course, it's very important for, regardless of any reason someone's seen in clinic, to go over someone's medications, but in particular, those who have cognitive impairment, because a lot of medications can cause cognitive impairment. The list you have in front of you are the common classes that we associated with cognitive impairment. So multiple studies have shown an association between short-term use of certain medications, like the ones listed in front of you, and cognitive impairment that is transient and reversible. So some patients who are on these medications for other reasons, if you stop taking them, their cognition can get better. But aside from these classes of medications that are typically on the Beers list, we also recommend looking at medication that we're using to control other medical conditions, like I mentioned earlier, like blood pressure and diabetes, because if we're over-treating our patients and they're having blood pressures that are too low or blood sugars that are too low, that's also detrimental and a harm to our patients. Next slide, please. Mood disorders is something to think about in terms of the development of dementia, and particularly depression. Depression has been shown to lead to an imbalance in stress hormones in the brain and reduce hippocampal volume and increase systemic inflammation. And that all leads to impaired cognitive function. It's been shown by various studies that depressive episodes are linked with incident dementia development, and even a history of dementia is associated with increased risk. So for that reason, we do recommend screening for dementia, for depression or anxiety with a PHQ-2 and a PHQ-9 if necessary, or a GAD-7 for anxiety, and really treating those conditions earlier on before they contribute to the development of dementia. Next slide, please. So sensory impairment is very common in our elderly population, in particular, hearing loss and vision loss. Hearing loss has actually been estimated to be the single largest modifiable risk factor for dementia. It accounts for about 8% of attributable risk to dementia. The mechanism that's been postulated how there's a link between hearing loss and dementia is that there's deafferentation-induced atrophy of the frontotemporal brain regions and a dysregulation of the cognitive control networks. So when someone has chronic hearing loss, they have lower available cognitive reserve and an increased susceptibility to functional impairment. So the interventions that they found that have been helpful in preventing dementia in patients with hearing loss include hearing aids. So hearing aids have been associated with an improved memory, global cognition, and executive function. Those who have more severe hearing loss who need cochlear implants, they've actually shown that once they've had their cochlear implant, that they have had improved memory, executive functioning, processing speed, and global cognition. So again, very important to screen for our elderly patients for hearing loss and vision loss. A lot of time we capture this during our annual visits or our Medicare annual wellness visit. And if we're able to address these risk factors earlier, we're able to affect all of this change that happens in the brain and hopefully delay or prevent the development of dementia. And similarly, vision loss also has a similar pathway to hearing loss. So because of the sensory deprivation, when you don't have your full vision, you have increased structural and functional changes in the brain. And there's also, of course, decreased emotional and social well-being that the patient experiences. In a systematic review of 110 studies, about 91 studies found there was a significant positive association between visual impairment and cognitive decline, in particular dementia. So again, screening for these sensory impairments and addressing them can really prevent or delay the progression of cognitive impairment, in particular dementia. Next slide, please. So I wanted to also mention other modifiable risk factors that were listed earlier. One of them being head trauma and traumatic brain injury. So it's been shown that repetitive head trauma can result in neurotransmitter release and calcium-mediated damage. So there's been a meta-analysis study showing that there's been an association between traumatic brain injury associated with 1.8-fold increase in the risk of developing dementia. And they've also shown that the MRI brain scans showing Alzheimer's disease brain versus a traumatic brain injury brain and healthy aging, there's more of a similarity between what the MRI scan of someone who has Alzheimer's looks like someone who has a TBI injury. So the interventions they're recommending are to pay close attention to these patients who've had traumatic brain injury with more intensive medical monitoring and health education, and work on the TBI prevention programs that can help reduce the burden of dementia. Another very common diagnosis we see in our patients is obstructive sleep apnea and other sleep issues. It's been pretty widely recognized that obstructive sleep apnea, because of the hypoxic episodes, it can lead to accelerated cerebral amyloid deposition. And several studies have shown that using a CPAP to address this has been associated with a delayed onset of cognitive impairment. Sleep promotes the creation of new brain cell connections, so it's essential that patients get enough sleep at night. So we really hope that we can intervene and allow for them to sleep at least 7 to 9 hours if possible, regardless of age. Vitamin D deficiency has also been shown to have some association between deficiency and development of cognitive impairment. A meta-analysis of 5 studies showed a higher risk of persons with serious vitamin D deficiency, meaning a level of less than 25 nanomoles per liter, compared to persons with sufficient vitamin D supply, meaning more than 50 nanomoles per liter. And they found that there was an association with those with vitamin D deficiency and development of cognitive impairment. However, the evidence is not very strong. So they're still looking into vitamin D deficiency and its association with dementia, but something to think about. Of course, substance use disorders, including tobacco use disorder or alcohol use disorder, has been associated with the development of dementia. A lot of the evidence with tobacco use disorder has to do with the cardiovascular system. In a study showing looking at current smokers versus former smokers, they showed that those who were current smokers had a consistently elevated risk of all-cause dementia compared to never smokers, and those who were former smokers but no longer smoking did not show these increased risks. So that tells us that there's a lot of support towards smoking cessation. So it's better to be a former smoker than a current smoker in terms of dementia risk. In terms of alcohol use, alcohol abuse has been associated with cognitive dysfunction and dementia. There's been some evidence of maybe light to moderate alcohol use may be protective, but I think a lot of that's still being studied right now. Next slide, please. So in the last studies, we really talked about more individual approaches to addressing these modifiable risk factors, but it's also important to think about the population approach at large, especially since dementia is going to become more of a prevalent condition. And individuals are a product of their environment, and a lot of this can be addressed at the population level. So this table on the right shows interventions that we can do at the individual level and those at the whole population level. So it's important to think about the social determinants of health of a patient and the patient environment. So for example, with obesity and physical inactivity, as clinicians, we're able to really modify the individual risks by identifying where the issue is and connecting with our individual patients with whatever resource can help them become more physically active. But at the whole population prevention approach, it would be looking into more structural changes. So that's something that, advocacy, public policy, legislative issues can address those. So maybe investing in walking and cycling infrastructure and making active travel easier and safer. Similarly, with high blood pressure, a lot of our patients, by the time they're diagnosed with high blood pressure, we're able to focus on how much salt intake they're taking in their diet and limit that. But it's also important to think about maybe preventing the high blood pressure from developing to begin with, working more on what foods that we're eating, that we're purchasing from the grocery store. So that would involve more legislation and working with the industry to reduce the salt content in our food. But I think this is something that research is looking into, and maybe in the future, there'll be more public policy to change these things so we can modify many of these risk factors at the same time, much, much earlier on before the patient presents with these symptoms. Next slide. And I think that's the end of my presentation. I'm going to go ahead and go over our case presentation. Next slide. Next slide. So this is Mrs. G. This first encounter, she came to see me to establish care, came with her husband, who's a retired pediatrician, and he was the one who provided most of the history. At this point, the patient wasn't a very good historian. She was a little bit confused about what was going on. Her husband was concerned because he's noticed that she's become even more forgetful over the last year or two, and she's not eating very healthy meals anymore, and he's really concerned. So she comes and sees me. Her past medical history includes hypertension. So everything here in red is to highlight the modifiable risk factor. So she's hypertensive. So we know that she has a risk factor of developing dementia if we don't control that. She has a history of hepatitis C that's been treated. History of breast cancer on letrozole. She sees an oncologist and that's under control and in remission. Has a history of skin cancer and that's also been taken care of. And she has a history of anxiety. So again, that's highlighted, again, a mood disorder to think about. Her family history is pertinent for both mother and brother had Alzheimer's disease. So these are non-modifiable risk factors, but good to think about since that increases our risk for developing Alzheimer's. Her current medications listed here include trazodone. I highlighted because it's an antidepressant and that can affect the CNS system. So something to think about in terms of cognition. Her function overall, she's independent with all her ADLs, but needs help with several IEDLs. Including cooking. So she used to cook, but now she's eating a lot of microwavable meals, a lot of peanut butter and jelly sandwiches, and her husband really concerned by this. So on the exam, her heart and lung were okay. Only thing on her heart exam was that she had an irregular rhythm, which was new. The rest of her exam was unremarkable. I did a neuro exam and it was fully intact. And I asked her husband if she's ever been diagnosed with anything like atrial fibrillation or any other arrhythmia. And he knows her pretty well. And he said, no, that's never been diagnosed before. That's new. So during this visit, since it was my first visit meeting her, we went ahead and sent her for some blood work to get a sense of any reversible causes of the cognitive impairment and get a sense of her overall health. We started her on a beta blocker because her heart rate was a little bit on the higher side, given her atrial fibrillation, and we started her on anticoagulation. At this point, we don't know how long she's had atrial fibrillation. We referred her to cardiology for help with atrial fibrillation management. And because the husband's been so concerned about the diet that she's been following, we refer her to a dietitian to help with ideas to keep her healthy as we can. And then I asked her to come back for a memory evaluation so I really can focus more on the memory. Next slide, please. So she comes back to me 1 week later. She's had her labs done and she's working on getting to see cardiology and she's planning to see the dietitian soon. So just a little bit about her social history. She is a retired nurse. She worked as a nurse at the VA and she retired in 2018. She lives with her husband and she has 2 dogs and she has a daughter who lives close by. The husband provides much of the history in terms of memory loss. So she's had a gradual memory loss over the last year or 2. She's had a decline in self-expression, increasing difficulty with comprehension, and increasing need for assistance in several IADLs. So I go ahead and do a MOCA, and I listed here for you the different domains where she lost points. So she was unable to, I think, perform the clock completely. So she lost the points on the visual, spatial, and executive functioning assessment. She lost points on attention, sorry, excuse me, my computer just stopped. Give me 1 second. Okay, sorry about that. I was just logged out. So again, on the MOCA, we were looking at the attention. Language was also, she lost points on language, delayed recall, orientation. So overall, her score was 17 out of 30, which is abnormal. So at this point, because of her functional impairment, and she scored objectively, she scored poorly on several domains. I was pretty confident that she probably has Alzheimer's dementia. So I went ahead and referred her to neuropsych testing for further testing to kind of tease out if there are any other etiologies potentially, since she has a history of anxiety. At this point, I'm not sure, maybe she's had a stroke in the past because she's had the atrial fibrillation, who knows how long. So for that reason, I ordered a brain MRI. I referred to social work resources to connect the husband with caregiving resources, since she's not cooking very healthily at home, and any other caregiving resources that he can need. And then for the atrial fibrillation, at this point, her heart rate's well controlled. She's on the anticoagulant. She's doing well, and she's planning to see cardiology soon. Her hypertension, it was a bit uncontrolled during this visit, so I really worked on that, and we managed her medication. So again, those in red are to highlight the modifiable risk factors that I've been addressing during these encounters. Next slide, please. So she sees our dietitian here at UCI, and they go over her diet history, and they come up with a recommendation for a low sodium and a cardiac diet. So eating more whole fruits and vegetables. They come up with ideas like buying frozen food, frozen vegetables, and that she can microwave for easier preparation. They come up with different protein sources with less sodium. She encourages reading food labels, looking at serving size and amount of sodium, and to encourage physical activity. So the goal was for her to eat 3 well-balanced meals a day with 2 snacks in between, with a limit of 2,000 milligrams of sodium per day. Next slide, please. So she comes back to see me appointments number 3 and 4, mostly to focus on the atrial fibrillation and the hypertension. Some of her heart rate was a little bit on the higher side, and her blood pressures are also elevated. So I really focused on modifying those medications during these 2 appointments. So we really focused on making sure her blood pressure was under control. But by the end of at the end of appointment 4, I think we had a pretty good handle on the blood pressure and the heart rate control. Next slide, please. And this is the image of her MRI brain. This is her actual scan. She had a mild cerebral volume loss and chronic microvascular changes. There was no evidence of an acute ischemic event in the past, no masses, no other changes or any structural changes that were concerning. So at this point, maybe there was some sort of combination of vascular and Alzheimer's dementia. Next slide, please. So she comes and sees me for this last appointment. At this point, she's seen our neuropsychologist here, and they did a full battery of testing, and they were able to confirm that it's likely Alzheimer's dementia, mixed to moderate, with possible vascular etiology given her cardiovascular history with atrial fibrillation and her MRI scan. So again, these are in red are the different modifiable risk factors we focused on in these 5 appointments with me. So blood pressure control, by the end of this appointment, her blood pressure has been well controlled, and she's seeing cardiology now for the management of atrial fibrillation, which has been controlled now. She's very physically active, which is wonderful. She likes to walk her 2 dogs every day for 30 minutes at a time, and that makes her very happy. We also connected the husband with Alzheimer's Orange County for resources for cognitive stimulation activities. And at this point, she has a caregiver now who's able to cook healthy meals. So again, the different modifiable risk factors that these are 5 appointments I was able to address as I was working her out for the cognitive impairment, which we eventually determined to be mild to moderate dementia. So with that, I'm going to end my presentation. So I'm open for any questions if anyone has any. Thank you so much for listening.
Thank you so much, Dr. Diaz-Mbuja. We do have a question in the chat, but for those on the line, please don't hesitate to raise your hand or put a question in the chat or simply shout it out. We're happy to get the information to you. But Dr. Diaz-Mbuja, your question from the chat is from Catherine White, who writes, in our FQHC and IPA, we have very little to no access to neuropsychological testing. Any thoughts or recommendations for how to proceed given these limited resources?
Yeah, I think that's a tough question. I work partly at the FQHC here at UCI in Santa Ana, and we have a geriatric clinic there that I help run. So I as a geriatrician trained in cognitive impairment assessments, I'm able to help with kind of meeting that gap in these patients. I think a lot of it has to do, if you're able to refer out to neuropsychology in the community, if it's someone that's really difficult case, because we've had cases where it's hard for us to tease out what the etiology is, or maybe there's something that is not clear. So there's a suggestion of referring to neurology, and they can also connect patients with neuropsychological testing. It does become harder when patients are self-pay or have low insurance or are uninsured. So that does make it more difficult. So yeah, I think it just depends on what resources you have in the community, but maybe a referral to neurology would be a good idea, especially in cases where it's too hard to determine what the etiology is.
Thank you, Dr. Dazenbuha. Next question.
And can may I say one word?
Oh,
And that's all true, but in cases where you just don't have the ability or you don't have the access to refer to a neurologist, you know, this series is set up so that we can empower the primary care providers to really act on your own. If you have neurology, that's great. If you have a geriatrician, that's great. But we're hoping through this series to be able, again, to give you the information that so you feel comfortable at least detecting dementia, diagnosing dementia in many cases, and starting treatment. So stay tuned as we move forward with this program. Thank you.
thank you, Dr. Gibbs.
Thank you, Dr. Gibbs.
Next question for Dr. Dazenbuha. Would you discontinue trazodone?
That's a good question. I think I would have asked her if it was helping her for her sleep or her anxiety. I think when she saw me, she wasn't really taking it. So it's better to take something off that has adverse reactions if it's not helping. But it's just something to highlight and to think about. So I probably would have in her case, because it wasn't really, she wasn't using it and it wasn't really helping her. So in this case, I would have discontinued trazodone.
Thank you. Next question. Clearly sleep is important, but OTC or prescription drugs to aid sleep typically carry risks for dementia. What is recommended when sleep is elusive?
When sleep is elusive? Okay. So I think for sleep, we'd have to have the patient come in and get a sense of why they're having the sleep issue. Again, getting to the root cause. I've had patients who come in and the reason they're not sleeping is because they're waking up to go to the bathroom multiple times a night. So it's more of a urination issue. So really getting down to the reason for the sleep issue. Is it because of nocturia? Is it because of obstructive sleep? Is it obstructive sleep apnea? Is it because of anxiety, depression? If all of that's been ruled out, if someone has chronic insomnia, it's actually been shown that medications aren't very good. It's better to send them to a cognitive behavioral therapist for treatment of chronic insomnia. So insomnia that's been going on for at least, I believe, 3 months and is prevalent at least 2-3 times a week. So yeah, medications aren't something that we like to prescribe, like things like Ambien or Zolpidem. They're not. There's been a lot of association between those medications and cognitive impairment. So again, getting to the root cause of why they're having the insomnia. And if it's more of a primary sleep disorder, thinking about referring them to CBT.
Thank you. Next question. What are your recommendations on OSA screening in patients presenting with cognitive impairment?
Yeah, I think with OSC screening, I think we tend to fall onto the stop bang rule and seeing like their risk factors. But I think a lot of older patients typically don't have a lot of those presentations. So I usually ask if they're having issues with, waking up at night or apneic episodes, if they're waking up not well rested. And I have a low threshold for referring to sleep apnea screening because a lot of these patients, they're not necessarily obese. They don't necessarily have a large circumference around their neck. So a lot of older patients tend to have OSA without presenting with the typical things we learn about in younger patients. So usually my threshold is a little bit lower, so especially if they're waking up tired or they're taking naps during the day at odd times during the day, feeling not rested. Or if they have a partner that they sleep with, if the partner notices that they're snoring a lot or gasping or having apneic episodes, I would refer to a sleep study.
Thank you. Next question. Would the care plan be different for a patient with Alzheimer's versus vascular dementia?
Yeah, so with, I think most time there is probably a combination of Alzheimer's and vascular, like that mixed etiology. They have similar treatment plans. So in terms of medications, there's been, and I think for dementia treatment, but the acetylcholinesterase inhibitors have been studied both in Alzheimer's and vascular. So you can treat similarly both. But of course, the underlying thing that we have to focus on is cardiovascular health. So working on blood pressure control, diabetes control, cholesterol control, making sure that they're on the right medications to control whatever cardiac condition they have. So usually you treat them very similarly. It's not often that you see a very isolated Alzheimer's dementia or very isolated vascular. A lot of times it's a mixed etiology.
Thank you. Okay, next question. Your thoughts on melatonin for circadian dysfunction in Alzheimer's disease?
Yeah, I think melatonin is a good idea for the sleep-wake cycle abnormalities in Alzheimer's. So we do start that for those who have issues with sleep-wake cycles, especially in Alzheimer's dementia. So I would encourage thinking about melatonin supplements. Yes.
Would you start dementia cholinesterase inhibitors in this particular patient?
So I actually did. I didn't mention it in the treatment because I wanted to focus on the risk factors, but yes, in appointment 5, I did start her on donepezil. She had the mixed kind of etiology, more likely Alzheimer's, so I did start her on a low dose of donepezil. I just didn't want to add it since I really wanted to focus on the risk modifications, but I did.
Thank you. And next question, what are your thoughts regarding adult daycare?
I think it's a great resource for our patients to keep them cognitively stimulated and keep them from being socially isolated, especially now with the COVID pandemic a few years back and still ongoing. Like I mentioned in the previous slide, it's really healthy for their brain to be stimulated in various ways, not just passively with things they can do at home by themselves, but also more actively where they engage with other individuals. In particular, having conversations with individuals they don't know about or they don't know, that can also be very healthy for their brain because it makes them use different parts of the brain they wouldn't usually use.
Thank you. Thank you, Dr. Diaz-Mbuja. Any other questions for her or our team? Thank you very much. If you have any other questions, please don't hesitate to put them in the chat or reach out to us. We're happy to get back to you with an answer. But thank you so very much. Sorry, we have one last question here in the chat. If this patient has dementia, what agent would you recommend?
Agent you mean treating the dementia or for?
Dr. Rahimi, did you want to clarify?
Sorry, I meant depression.
Okay.
Oh, for depression.
Thank
Yeah,
you. Yes.
for depression, usually we'll start with an SSRI. So if her depression was uncontrolled, I would probably start her on an SSRI that we use typically for older patients that are less anticholinergic. So something like sertraline or citalopram. That's probably something I would start with.
Thank you. Thank you, Dr. Diaz-Mbuja. One other consideration might be if there was sleep dysfunction and depression or anxiety, you could consider mirtazapine or Remeron. Thank you so very much, Dr. Diaz-Mbuja. That was an extremely informative presentation. And thank you for answering those questions for us. And thank you to the audience for submitting those questions. Very, very happy to answer all of those. I'm going to turn it back over to Manahil.
Yes, thank you, everyone. Thank you, Dr. Diaz-Mbuja, for your wonderful presentation. So just moving on to closing and reminders, if you do wish to receive CMEs, please fill out the form at the following link, or you can scan the QR codes. We also ask that you complete the evaluation form as this helps with our continuous quality improvement efforts. This presentation and links will be sent in a follow-up email before the end of the day. I will also be sending out a link to last week's recording for anyone that may want to rewatch that. Also, please join us next Friday, December 16th for our office hours. So during that time, you may bring any and all questions related to dementia geriatrics. And I also will send out a Zoom invite at the beginning of next week with more information. So thank you again for your time, and we hope to see you all at our office hours next Friday.
Thank you, Dr. Diaz and Buha.
Thank you so much.